Right, now we're going to look at the lumbar posterior joints and determine specifically how we're going to do manipulation. We'll assume that our quick scan found something in the lumbar spine that wasn't springy and felt like it was blocked. We'll put our thumb to the right side of the spinous, rotate the patient, and push forward and see if rotation is springy. And what you're going to find is some of these motion palpations are passive movement to test the springy infeel, and some of them are joint play movements that the patient can't do themselves. But if you can't jiggle a joint in the joint play direction, which is specific, then that's going to be needing an adjustment as well. So we're going to do some palpations such as rotation P to A and see if it's springy. Then we're going to bring the patient back into slight extension, and the posterior joint should extend and feel springy. Then we're going to place our thumb to the opposite side of the spinous, and we're going to laterally flex the patient to the left. The patient's spinous wants to go to the left, to the concavity. That's the coupled motion. But we're going to block it, and that'll force the posterior joints to open in lateral flexion. And again, if it doesn't open, it'll feel blocked, and we want to see if it's springy. If it doesn't spring, we ask the patient, does that hurt? The patient will say yes, because it does hurt when you challenge a locked, non-springy joint. Then we take the pressure off. Does it still hurt? No. Now we know we need to adjust that joint, which is L2, L3. We need to adjust it in left lateral flexion. Then we want to see, place between the spinuses and isolate the flexion at your thumb and see if those spinuses open. If you let him flex at the hip, you're not going to feel it. So it has to happen right at your thumb, and the joint spinuses separate and flexion's occurring. And now we're going to block over the spinous and hyperextend and see if the anterior ligament is allowing the lumbar vertebra to open up at the front. So we have rotation, extension, lateral flexion, flexion, hyperextension. And from that, we'll know specifically all of those require a specific type of adjustment. One crack, one cavitation in the lumbar spine, in my opinion, is not going to do it. You have to make sure that you have the lumbar posterior joints moving in all those rotations around those three axes. The only one we can't palpate is A to P rotation. We're going to also palpate with this table long axis distraction of the lumbars, which is another range of motion. With this, we can also palpate the thoracolumbar junction. And you see he's a little rounded, but is he blocked? And you can literally pick this up. If you do, then you would come back and do P to A, extension, lateral flexion, flexion, hyperextension to see what we're going to do. Another way to palpate, if you lie on your side, Josh. That's it. Your knees together. Bend your knees. That's it. Hold on to the table. We want him to be perpendicular to the table. I'm going to take a hold of his lower legs, and I'll palpate just off the sacrum onto the fifth and try and lift him into lateral flexion, and he should laterally flex, and the coupled motion is rotation. So you should be able to feel that and go all the way up and feel if the lumbars are moving. For somebody that's big, this is a lot of hard work compared to sitting on the chair, but sometimes you're not quite sure. It's a way of getting a consensus of, is this blocked or isn't it blocked? If you bring just one knee up, you can also feel whether the interspinous space is open, which is flexion. So you'll be able to feel, if you think there it wasn't flexing, you can actually feel it a little easier this way than you can with them sitting. So what we're going to do now, if you lie on your back, we're going to assume that the thoracolumbar junction didn't flex very well. And we're going to adapt a supine move, cross the arms, hands over top of the traps, because that's going to create flexion for us. So I don't want their hands here, right over top, so that when I pull on his elbows, he's going to be pulling himself into flexion. We'll rotate him over. This hand is on top so that I can use it as a lever to rotate him rather than asking him to sit up. I'll come off the lowest rib and pick up T12L1, place my hand so that the spinuses are along my thumb. My hand is flat. You don't have to do that, which is going to hurt your knuckles. You can stay flat. It's enough of a fulcrum. So we're going to get flat in between those spinuses. If you would sit up towards me, come on up. I'm going to lift him a little bit, which puts him right onto the contact. Let your breath out and impulse. Because he was in flexion, it's going to cause flexion. So we're not going to call this an anterior thoracic move. We're going to call it what it does, and it causes flexion when I do it this way. If it's for extension, I'm going to lower the headpiece, set him up the same way over the shoulders, come in behind the same way, get my thumb between the spinuses. Only this time, I'm going to let him go to extension. Do a sit-up, bring him, move him a little bit, let go down, and he got past that headpiece, and we got a little cavitation of extension. So that was two of the possibilities in this junction. This junction is incredibly important. It causes a pulling of the cord, which pulls the roots, which stop at T12, and the roots go on down. And when they come down and become more obtuse because of a thoracolumbar dysfunction, it'll exaggerate discal trouble. It even causes pseudo-discal trouble. And it's extremely important in all your disc cases or any cases that are ontalgic to make sure that you get the thoracolumbar junction moving really well. In your main syndrome, females are going to have intrapelvic pain. Males are going to have pain into the groin, often testicular pain. They'll have a pain down into the SI joint. They'll swear something's wrong in their SI, but it's all to do with this thoracolumbar, first lumbar nerve root radicular syndrome. So what we want to do now is a side posture. So if you'll lie on your shoulder here, I'll give her head a little support. I'm going to bring her knee up a little bit. I'll extend the lumbar spine from the leg. I'll extend the lumbar spine, hand under the arm, hand there. And now we want to get extension. So I'm going to take a contact. This would be the left posterior joints between, let's say, 3 and 4, not extending. And I'm going to get my pisiform in over just on the superior side of the spinous. It is often called a mammillary contact. And I'm going to ask the patient, when I get extension, to stick her abdomen out. As she does that, she'll be letting go of the muscles that restrict extension. She'll be helping me get extension. And if I thrust into the resistance of extension, we'll get an extension release. There we go. So, we'll come up from the crest as 4, 4, 3, pisiform above the spinous. I'm going to have my knee to the side of the knee, my thigh to the side of the thigh, the way I did with stick your abdomen out. an impulse, and when I get that cavitation, she was going into extension, I was pushing into extension, and we got extension. How would I know? And this is something that's extremely important. Could you come back onto the stool? Your patients will really love it when you do an adjustment and then come back and recheck and see if you actually got it. So I would go to the left side, do that little extension move, and feel that it was now extending. And if you remember, I asked the patient, does it pain? So now I can ask the patient, does it pain? And because it's moving and not blocked at end feel, it won't pain. So the patient's going to feel that something that pained got adjusted, they heard it crack, they felt it release, they came here, it doesn't hurt anymore. It's a really good feeling to know something good has happened to you. It's excellent for the patient. Let's say that we didn't find L45 rotating on the left side from P to A. I'm going to set up what's called rotation counter rotation. I'm going to have 4, 5 coming towards me, rotating this way, and I'm going to counter rotate above so that 3, 2, 1 goes the other way. And we all know from physics, if two objects are going in two different directions, they separate. So if I can isolate that separation at the level that I want to release, then I can specifically introduce that movement. Again, stretch. Why are we stretching? There's research to show that joints that are distracted take about 50% less force to cavitate them than joints that are compressed. So we pull and separate. Same thing, bring the knee up to the level that you can feel the tension right there. We're going to be rotating. And I'm going to reach over here, get on top of the spinous above, and with a little pressure, I'm not going to thrust on her shoulder, but I'm going to pull her pelvis, pull 5, pull 4, and just restrict 3. Again, I want to have that contact so my pelvis is turned, an impulse, and get a little release. It's extremely easy because those want to go that way. I'm pulling these this way. It doesn't take a big force, just a little tension on the knee, thigh to thigh, where I'm powerful. Then I have to learn to lean in, even though I'm staying that way, to get that rotation, counter rotation. Patient, I would bring them back, palpate, see if there's rotation. Let's say we found left lateral flexion wasn't occurring. For this, we need to drop the center piece, and the patient has to be perpendicular to the table. So the patient will hold the table, same side posture, same pull, same pull, and you see she opened an inch or two there, which made some traction. There you go. This time, same thing with the knee. I'm going to palpate to see that the tension is at the level I want to adjust, which is right there. I'm on the spinous. I'm going to trap, but not drop on the knee this time. What I want to do is I want to drop down on the spinous, shoulder, body drop, and drive her spine down into that gap, which is down that way. And you see now I am dropping my body, but my hand and thumb are very much on the spinous, very much pushing. Some like to take a pisiform contact and do the same thing. Thrust down, make the spine open. You'll get a cavitation. Turn over on the other side. I want to show you that knee contact again. Patient up, pull, pull. Bring the patient over to the edge. Palpate. This hand takes the knee. This hand is palpating like you saw. Only what I have to do is get my knee and my thigh, thigh to thigh, knee to knee. This is very difficult to do when you're learning it. So you have to persevere. That's it. We don't want hold the table. That's it. We want to drop into the centerpiece and drop. And this side, it released quite easily. Now, I hadn't palpated her, so I wasn't sure if there was a restriction there. But obviously on that side there was, and as soon as I dropped her into that cavity, we got lateral flexion. Okay, thank you very much. Flexion is difficult. What we do is we reverse the flexion that we did at the thoracolumbar junction, and this time we bring the knees up, and we're going to push on the knees instead of pushing on our elbows, and we're going to get around in behind. And this is, my fingers are like that. I'm each side of the spinous. There we go. And all I have to do is push down towards my fingers, impulse, and we get a separation of flexion. If you lie on your side this way. On smaller people, bring this knee up, hold the table. We've pulled to get the distraction. On smaller people, children, we can do flexion from here. So the knees are right up, she's forward, we can see it's flexed, and what we need to do is push on the upper one and we can get flexion. I wouldn't do this method with her, I would do the first method that I showed. But for young, smaller people, you can do that particular move. The next thing we need to do is the standing lumbars. Josh, do you mind if I do that with you? Lie face down. There we go. If I place his pelvis just on that lower table, and I have him hold this T-bar, and I start this table, drop this centerpiece, I should be able to feel long axis distraction. Because he's hollowed in here, he hasn't become flexion distraction. He's staying parallel, and I've seen this on motion x-ray studies. With the belly dropped and the lordosis still there, these are distracting parallel. So we should be able to feel the spinuses separate. Some people motion palpate, there you go, by going sideways, see if the rotation occurred towards them, push and see if the lateral flexion occurred, pull on the spinous, see if it, and you can literally motion palpate while that distraction is going on. And it's a fine way to do the same thing. But if I discovered that that distraction wasn't occurring, I could either place the heel of my hand or even cross so that I'm pushing down and pushing up and cause a little distraction. However, there's a classic move in chiropractic that does that really well. If you'd stand up, Josh, just face that way. What I'm going to do is place the back of my back, my sacrum, just above his. I'm going to get in through his arms. I'm going to walk forward and make sure that he doesn't lean backwards, because I don't want to hyperextend. I want to get long axis distraction. So he'll be instructed to bend his knees slightly. So I'm going to show you what I don't want you to do first, and then I'll show you what needs to be done. Just give me... All right, what we don't want is this. All right, That's going to hurt him. It's going to force hyperextension. It's going to bruise the joints. And what we're looking for is long axis distraction. It's a joint play move. We can't make ourselves go that way, but they need to. So, if you'll just bend your knees, there you go. I'm going to make little tiny steps. His weight is now on my sacrum, and I'll lift him. His feet came off the floor about that much, and if there was a fixation of long axis distraction, that would have caused a lift without hurting. And if it needs to be done, rolling, rotation, those manipulations don't free that direction. Manipulation is specific around these three axes and the translation down these axes. So we're always rotating with a manipulation around one of these axes in one of these directions, or we're doing translation down them. Well, that pretty well covers the manipulation, adjusting of the lumbar spine. However, there are some patients that are very ontalgic, and we need to do what I call mobilizing in extension. And for this, the patient sits on the end of the table, and I need to get both thumbs. So let's say his thoracolumbar junction, he's lost his lumbar curve. We can't adjust him. He's in a very painful state. This particular maneuver, we'll call it mobilization, actually gets the ball rolling and starts to give the patient a bit of relief. Sometimes I can even do a manipulation the same day that I do this. Sometimes I can only do this and have to wait until tomorrow to get something that cavitates for me. So what I'm going to do is place both my thumbs each side of the spinous, and I'm going to ask him to push against my thumbs and then lean back. And I have to get lower than my thumbs. Lean back over my thumbs. There you go. And this forces extension. Let your breath out. And he just moved a bit more on exhaling. Let your breath out and keep pushing. And with that, I can get some extension started. Sometimes it even cavitates. But the patient often will stand up and get a great sense of relief from doing that. And if they do, I'll bring them onto the table and try and do a specific manipulation. Okay, what we covered was flexion, extension of the lumbar spine, specifically the thoracolumbar junction. We did a rotation, counter-rotation. We did extension, and we did lateral flexion between the posterior joints of the lumbar spine. In a spondylolisthesis, if it's congenital, their nervous system has learned to get around the spondylo from the time they were born. And in my experience, the thoracolumbar junction is what pulls on the roots and doesn't allow them to get around the spondylo. There's a lot of good pictures in the biomechanics of the central nervous system by Alf Brieg, where he has actually photos of how those roots go taut when the thoracic junction, lumbar junction, isn't functioning properly. For disc and facet, there are two tests that for some reason are not standard in chiropractic that I believe should be. The first is for a disc. The patient straightens their painful leg, which often in a disc they can't do that. You have them slump and you bring their chin down to their chest. And if that shoots a pain in the leg, it's positive for disc. And in Europe, that's called Neary's test, and it's considered pathognomonic for disc. No false positives, no false negatives. They either can do that and get no pain, or they do that and get a shooting pain down the leg. If it shoots in the leg, you better take an MRI and find out whether you have a protrusion or an extrusion. Now for the facet syndrome. Could you lie face down? This comes from Manel. If you spring over the facet, one side and the other, it'll hurt and it'll linger if it's inflamed, facet syndrome. But here's the amazing thing. Put your hands behind your neck. Lift your head and shoulders up off the table. He's now using his extensors, and I can't spring that joint. It won't hurt. So amazing to the patient. They're actually active, working, doing this extension. I push. I could do a handstand and it wouldn't hurt. As soon as they relax, let everything go loose, spring it again, and it hurts. So what we have is a sequence of pain when it's relaxed. You jiggle the joint, it hurts. You get them to lock the joint in active extension. You spring it, it doesn't hurt. And that relax, and it does hurt. You now know that you have a facet inflammation. Quite often you have disc and facet together. Both tests will be positive. And it's not uncommon, and we have to get used to the idea that single diagnosis is usually wrong. There's usually multiple things happening with patients. With Main syndrome, you will push up through here and they will feel the pain at the SI joint. And you can do that when they're sitting and compress, or you can do it when they're lying. What I like to do is the skin roll. And a lot of people think rolling the skin is the skin roll test. What it is, it's dragging your thumbs through the skin. So as I drag along, I'm going to take this hand away. You'll see this thumb rubbing. I'm rolling the skin with my fingers, but my thumb is rubbing. If there's facilitation of the sympathetic nervous system, this is going to find an exquisitely painful spot. It'll also cause a red reflex. And if you take a pinwheel or a sharp pin from your reflex hammer, you'll find that it's hyperesthetic on one side, more painful, and less painful on the other side. Sympathetic facilitation is usually unilateral. So you will get the red reflex on one side, about the size of a 50-cent piece, will become red. It'll become very painful to skin roll, and the pin will be hyperesthetic. When you palpate this patient sitting, they often break out into a sweat. And that's another sign that the sympathetics are facilitated. Hopefully with these techniques, you're going to be adjusting people to get a neural response, not just a musculoskeletal change. You have to change the musculoskeletal locomotor system. You have to analyze that system. I kind of like keeping score. But the actual benefit, health benefit to patients, is when you change spinal function by changing the whole kinematic locomotor system and getting the facilitation of the sympathetics back to normal, so that when you skin roll it doesn't hurt, there's no red reflex, the pin becomes dull, and they don't sweat when you palpate through that area. At that point, they start to heal. A lot of times we think that we should be able to adjust and see a result. You have to get their spine back to normal, and then the healing response takes place. Then nature can take over. So you must have a series of adjusting, getting patients back to their normal locomotion, getting the sympathetic facilitation removed, and then let your patient expect things to start happening. Of course, little things happen along the way. They sleep better, they digest better, they do this, they do that. And they'll be telling you, you can't stop them from telling you how they're starting to respond. But don't give them the expectation that today's adjustment is the miracle tonight and tomorrow. There are no miracles. There is just normalizing the sympathetic nervous system, getting rid of inflammation of joints, getting muscles recruiting properly, getting things so that the locomotor system functions properly. That takes time. That's why we call it serial adjusting, to get a specific adaptation to the imposed demands of our treatment, our exercises, our stretches, all those things we do. The nutritional changes, all demand a response by the body to make a healing. Thank you.